Is breast cancer the answer? In this poster, we present a rare case of Budd-Chiari syndrome from metastatic breast adenocarcinoma. Budd-Chiari syndrome, or BCS, is a rare condition caused by hepatic venous outflow obstruction. It can present with a range of clinical manifestations from abdominal pain, hepatomegaly, and ascites to hepatic encephalopathy and even acute liver failure. It typically results from a thromboembolic event, but can also be caused by external compression of hepatic veins, such as by a malignant tumor. In fact, malignancies account for about 10% of cases of Budd-Chiari syndrome. Several malignancies are associated with BCS, including hepatocellular carcinoma, as well as metastasis from the adrenal gland, kidney, lung, pancreas, and stomach. However, breast cancer is a rare cause of Budd-Chiari syndrome. Up to 50% of those with breast cancer develop liver metastasis, which usually presents as nodular disease and rarely leads to liver failure. To this point, metastatic breast cancer presenting as BCS has not been published. Here, we report a case of an otherwise healthy female who developed fulminant liver failure secondary to Budd-Chiari syndrome caused by metastatic stage 4 breast cancer in the absence of a discrete liver mass. In this case, a 64-year-old woman with a past medical history of hypertension presented to the hospital for a 1-week history of severe right upper quadrant abdominal pain. She also complained of weakness, nausea, and intermittent confusion. Vital signs on initial presentation were normal. Initial complete metabolic panel revealed a mixed hepatocellular and cholestatic pattern with elevated AST, ALT, and alkaline phosphatase levels. Total bilirubin and direct bilirubin levels were elevated, and INR was normal. Testing for viral hepatitis was negative, and she had no history of alcohol abuse. Right upper quadrant abdominal ultrasound was done and revealed hepatomegaly, but did not show evidence of a thrombus. Subsequent CT abdomen revealed heterogeneous hypoattenuation throughout both hepatic lobes and small volume perihepatic ascites. An incidental 1.5 centimeter mass was also found in the left breast, as indicated by the yellow arrow. The patient reported a normal mammogram a few years prior. Abdominal MRI was then ordered for further evaluation and revealed a markedly enlarged liver with multiple foci. These findings were suggestive of the regenerative and dysplastic nodular pattern classically seen in Budd-Chiari syndrome. The inferior vena cava was narrow at the side of the liver, as indicated by the black arrow, and this was thought to be secondary to compression caused by possible hepatic infiltration. Since no visible thrombus was visualized on imaging, an ultrasound-guided core needle liver biopsy was done to characterize mass lesions. Pathology revealed low to intermediate grade adenocarcinoma, staining positive for tumor markers suggestive of a breast primary. HER2 staining was positive, while estrogen receptor and progesterone receptor staining was negative. The patient was subsequently discharged from the hospital with a diagnosis of stage 4 adenocarcinoma of the breast with metastatic disease to the liver and was instructed to follow up with oncology as an outpatient. However, she returned to the hospital 5 days later with worsening abdominal pain. At this admission, liver enzymes had worsened to over 1,000 and prothrombin time was now prolonged. She was diagnosed with acute liver failure secondary to Budd-Chiari syndrome caused by extrinsic hepatic compression from diffusely infiltrated metastatic breast cancer. The patient's condition deteriorated rapidly within 1 week, and she became altered and lethargic, requiring airway protection. She was transferred to the ICU, intubated, and placed on pressor support. Throughout the next week, her clinical picture failed to improve, and she was withdrawn from artificial life support. This case is important for 2 reasons. First, to this point, metastatic breast cancer has not been a reported cause of Budd-Chiari syndrome. When there is evidence of a visible thrombus on imaging, liver biopsy is often not needed. However, in cases where a thrombus or overt hepatic lesion are not found, as seen in our patient, biopsy may be helpful to reveal an underlying cause and to subsequently guide treatment. The second reason this case is important is for planning a treatment protocol for unusual presentations of Budd-Chiari syndrome. Since the primary cause of BCS is thrombosis, treatment often includes anticoagulation, TIPS procedure, and liver transplantation. Our patient, however, would not have been a candidate for liver transplantation because of her stage 4 breast cancer. In order to correct the obstruction seen in her case, treatment of underlying metastatic disease with chemotherapy or immunotherapy would have been necessary. Unfortunately, her disease progressed to liver failure too rapidly to receive any treatment. Early recognition of Budd-Chiari syndrome is essential to improve survival. Patients with Budd-Chiari syndrome without evidence of thrombosis or a liver mass should raise suspicion for infiltrative malignancy as a secondary cause. Because patients with Budd-Chiari syndrome who also develop liver failure rapidly deteriorate, early diagnosis should be obtained with liver biopsy in order to guide treatment and increase survival.